Thank you. Good morning, everyone. My name is Vitor. Very happy to be here today speaking about exercise, which is a topic that I love, especially as an exercise physiologist. And I apologize for the size of the slides. I think some figures are going to be a little smaller. But these are some secondary analyses from the health study in which Christine Erlandson presented some data yesterday. We finished recruitment for this study a few months ago, so we have a lot of papers and results in production. Just as a quick introduction, frailty and sarcopenia are both prevalent in HIV. They are mostly age-related conditions, but they have some main mechanisms which are more related to chronic inflammation and mitochondrial dysfunction, which are very prevalent in people with HIV. And as a result, they help to increase the prevalence of sarcopenia and frailty. And for these two conditions, there is no pharmacological treatment that is currently approved. And exercise is the main way to prevent and treat both sarcopenia and frailty. Also about exercise in this population, people with HIV greatly benefit from exercise interventions with improvements in several domains. But research has been shown that some higher intensity of exercise may be necessary for more profound change and benefits in people with HIV, especially when we talk about mitochondrial dysfunction. And that was the idea behind trying a HIIT intervention with these patients. The high-intensity interval training has several benefits and greater benefits in several populations, but we basically did not have any large trial in our population. Before our study, there were only 2 or 3 pilot studies that have been done before with very small samples. So we try to gather more evidence around the HIIT for people with HIV. Also, the idea to do some secondary analysis for frailty and sarcopenia is that there is a scarcity of data on the benefits of exercise for sarcopenia and frailty in people with HIV as well. So the aims of this presentation is to compare the effects of our intervention on frailty prevalence, and also I included some data on sarcopenia, and also to explore the association between frailty status and the likelihood to withdraw from our intervention. Additional information from the health study. So this was a 2-site randomized clinical trial that happened in Seattle and Aurora, Colorado. Data for part 1, which was the exercise intervention for health, was collected from March 21 to February of this year. Randomization for our study was balanced by study site, birth, sex, and age, and participants were randomized to either the high-intensity interval training and the continuous moderate exercise. So this was just a different approach for the aerobic training for the exercise, and then everyone did the same resistance training. And the study team and the participants were not blinded to the intervention arm, which is a difficult thing to do in an exercise intervention. This figure is just to illustrate our design. It's to show how complex and long the health study was. And actually, there was a 2-part study. So we first had an exercise intervention for 16 weeks, which was followed by a biobehavioral intervention for additional 12 weeks. So we tried to increase the physical activity levels of the participants, and then we tried to see if we could keep those activity levels high after the intervention, which is a main challenge with this population and a main challenge that you see in exercise interventions. Usually they do very well in the gym with us, but after the intervention is over, they don't do anything else when you follow up with them. Regarding our inclusion and exclusion criteria, all of our participants were 50 years and older. They had a sedentary lifestyle. They were fatigued. They had TSH levels with normal lab limits to limit the influence of fatigue on our outcomes. And they were stable for HIV treatment and on ART for more than a year. And our main exclusion criteria was related to hormone replacement, if they were just starting some hormone or changing the dose. Also anemia, cancer treatment, orthopedic problems, and then uncontrolled hypertension or diabetes. A little bit more about exercise intervention. So they exercised for 16 weeks, and the exercise was a combination of aerobic, mainly on the treadmill, and then resistance exercise on weight-bearing machines. They had 3 exercise sections per week, and we encouraged them to come on non-consecutive days to have some rest in between the sections. They were randomized for HIIT or CME for the aerobic portion, but all participants performed the same resistance exercise. And the intensity and duration increased during 8 weeks and then was maintained until the end of the intervention. These are more details about intervention, but the only thing that I want to highlight here is that, especially for the HIIT participants, they were able to exercise at 9% of their heart rate reserve, which is a very high relative intensity that we didn't know if this population were going to be able to achieve, but also they did it, which was great. Regarding the frailty assessment, basically that was done with the Fried frailty phenotype, and we scored there according to standard procedures. For sarcopenia assessment, the field of sarcopenia nowadays has some challenges in which we have different definitions and they don't talk to each other. So we explore 3 different definitions, actually 2 definitions, and then one of the definitions with some specific cutoffs that were proposed for people with HIV. Statistical analysis, I want to highlight that the health study was not designed to treat frailty, so the sample size calculation was based on changes in 400-meter walk test, and frailty was treated as a binary outcome in our study, in which we analyzed non-frail versus pre-frail and frail. So in general, in the study, basically we had 118 people who were randomized to the study, and we had 24 dropouts. So there was an average of 80% retention rate, which is very good actually for studies in people with HIV. Also, the attendance to the sections were very high. We had 95% of the participants who attended at least 80% of the sections. And we had about 40% of the participants who attended all the exercise sections over 16 weeks. Characteristics, our participants were 58 years old as a median age. We had a few participants on the 70s, which was very nice to see them exercising. They were living with HIV for over 20 years, mostly male, white, and non-Hispanic. In general, our sample was highly educated and had the presence of several comorbidities, and I want to highlight the prevalences for overweight and obesity according to the BMI. Basically, we had only 25% of the participants who were on a normal or healthy weight, and all of the others ones were overweight. Regarding frailty parameters, we had only in the whole study, we had 5 participants who were classified as frail, and from the ones who completed the study, we had only 3. So there was a low prevalence, and we have about 50% of participants who are pre-frail. The prevalence for sarcopenia were very low across all definitions, but what we saw pre and post is that there was an improvement in frailty classification and also in some components of frailty, especially low activity and exhaustion. The changes were similar in both study arms. There was a low prevalence of sarcopenia and a lack of agreement between the definitions. And regarding our frail participants, we have 2 withdrawals. 2 of them changed to a pre-frail status, and 1 of them changed from frail to non-frail, and this was in the HIIT group. Regarding the likelihood to withdraw from the intervention, for the frail participants, we had 40% of them who dropped out of the study, 27% of the pre-frail drop out, and then only 11% of the non-frail drop out. So the prevalence increase according to the frailty status, and when we compare non-frail versus pre-frail and frail, the pre-frail and frail had a higher likelihood to withdraw from the study. We also did some exploratory analysis on the influence of frailty status in the improvements in the 400-meter walk test, which was the main outcome for the study. What we observed was, and also for the promise fatigue, what we observed was frail and pre-frail participants had lower scores on the 400-meter walk and on the promise fatigue at baseline. And for the 400-meter walk test, people who are frail or pre-frail, they had more higher improvement in the 400-meter walk test along the intervention, which was more related to a normal return to normal effect, because when you look at the results at the week 16, basically all of the participants ended up in the same range of results and didn't have differences between non-frail and pre-frail after the study. Just highlight some additional results from our study. Participants had a high fidelity to the prescription and were able to achieve a high intensity heart rate. There were benefits in improvements in muscle strength, physical function, body composition, and fatigue. And as a conclusion for this analysis, our intervention decreased the frailty prevalence and was also able to improve some of the frailty components. And participants who were frail or pre-frail were more likely to withdraw from the study. And future interventions could think about some optional type of training, maybe less intense, in case you have more frail participants in your study. So you can try to keep them in the study and also benefiting from exercising. As limitations for this analysis, that our participants were medically stable and lived in cities where people are ranked among being very active. So they were much more robust than what we would expect from older people with HIV. And the study wasn't really designed for this population. And I just wanted to end with a call for action, just following Christine Zerlandson's speech yesterday, that we have several benefits for exercise in many outcomes. For some comorbidities, exercise not going to be the only solution. It's not going to solve all the problems, but definitely ameliorates every condition that our population, especially older people with HIV, are experiencing nowadays. Just wanted to conclude and thank
Victor, I think we need to conclude. Yeah, we want to
thank our partners and co-authors and the PIs for this study, and thank you for the audience.